Hi, good afternoon, everyone. My name is Rie Tai from the Asia Dengue Policy Working Group. We're very excited here to start off the panel discussion, Testing of Dengue Use Cases Across the Care and Control Continuum. Before we start, I wanted to provide a short introduction about the Asia Dengue Policy Working Group. We're a partnership between EquiHealth and Asia Dengue Voice in Action. And our goal is to support the WHO's goal of achieving zero dengue deaths by 2030. By elevating dengue as a priority at both national and regional levels, we aim to advocate for increased awareness, resources, and action towards dengue control. This can be done by unifying diverse stakeholders and experts and developing an official platform to cultivate policy discussions and campaigns dedicated to designing and implementing effective strategies for dengue prevention and management. So this slide. Our priorities cover topics from vector control, entomological and patient surveillance, vaccination, diagnostics, and care management. The Policy Working Group was established in April of 2024, and since then we have had the opportunity to present our research in several conferences, and also recently launched a policy map and a white paper. The dengue policy map provides a detailed assessment of dengue prevention and control strategies across 10 countries in the Asia region. And the white paper collates insights from the policy map and introduces best practices of dengue control, and also introduces recommendations at the regional and national level, such as data sharing mechanisms and development of a dedicated national task force to drive multi-sectoral coordination for countries that have yet to develop a dengue task force. And testing is a key component to ensuring effective management of dengue. And with that, it is my honor to introduce our moderator for today, Dr. Christine de la Cruz.
Thank you, Rie, for setting the stage for our next panel discussion on diagnostics. Before I start, may I ask our expert panelists to please join me on the stage and take a seat in the firing squad. Just joking. No, of course, we're very honored to have with us today our distinguished panelists. So good afternoon again, everyone, and welcome to our Dengue Diagnostics panel. I am Dr. Christine de la Cruz, and it's my pleasure to be your moderator for this crucial panel discussion on testing of dengue, use cases across the control and care continuum. So as you know, dengue remains a significant public health challenge, particularly in our region. Effective testing strategies are paramount, not just for individual patient care, but also for robust public health surveillance and outbreak control. Today, we aim to delve into the various testing strategies across the continuum of dengue management, from case detection and informing vaccination strategies to understanding the critical role of different test types by purpose and timing. So, for this panel discussion, I know you have a lot of questions, and since we have a lot of attendees, we prepared a Slido for everyone. So if you have questions, you can put them in using this QR code. So if you don't know how to use it, ask your seatmate who can help you. So before we dive into our discussion, let's briefly orient ourselves to the main types of dengue diagnostic tests and when they are typically employed. Oh, sorry. So, I'm sorry. So, were you able to scan the Slido? I'll give you about a minute to key in some questions, pre-panel questions that you have, if you do. All right. So after this, we will see the answers to some of the questions in the Slido. Okay, so we're getting in some answers. To what extent do the current diagnostic guidelines support dengue diagnosis and management? So, it's a range from 1 minimal to 5 comprehensive. So, basically it's more than, majority is at 3 or 4, mostly in the 4. That's good. All right. So next, how well are the diagnostic clinical guidelines adopted in your country? Well, thankfully, no one answered 1, mostly in the 4 region. So mostly very well, 16% very, very well. Okay, next. Okay, so before we dive into our discussion, let's briefly orient ourselves to the main types of dengue diagnostics tests and when they are typically employed. We have been reiterating this throughout but let's review. So we have the NS1 antigen tests. These tests detect the NS1 protein, which is produced by the dengue virus itself. They're most effective during the early acute phase of infection, usually within the first 5 to 7 days of fever onset, when the fever is actively circulating in the blood. IgM and IgG antibody tests. These serological tests detect the body's immune response to the dengue virus. IgM antibodies typically become detectable around 4 to 5 days after the onset of fever and remain elevated for several weeks, indicating a recent or current infection. IgG antibodies usually appear shortly after IgM and can persist for years, indicating a past infection. Next, we have your nucleic acid amplification tests, including your PCR, your CBC, and of course, your genetic testing. Again, I am honored to introduce our distinguished panelists today who bring a wealth of experience to this discussion. First, we have Prof. Ruki de Alvis, Deputy Director, Center for Outbreak Preparedness at Duke NUS, and from the Asia Pathogens Genomic Institute, Prof. de Alvis, welcome. Next, we have Dr. Solante, Dr. Ronjean Solante, Chairman of the Adult Infectious Diseases and Tropical Medicine Section of San Lazaro Hospital in Manila. Dr. Solante, it's great to have you with us here today. And joining us is Dr. Raul Destura, a microbiologist and infectious disease specialist from the National Institute of Health, University of the Philippines, Manila. Dr. Destura, welcome. Okay. So, before we delve into our panel's expert insights, I'd like to briefly open the floor to you, our audience. We're keen to hear directly from those on the front lines. Okay, so what are some of the most pressing difficulties or persistent issues you've encountered in your experience with dengue diagnostics or laboratory examination? Perhaps it's related to access, turnaround times, interpretation, or specific test limitations. Please feel free to share your perspective briefly in our Slido, or you can take the microphone and do it old school. Okay, no responses so far. I think they're all eager to hear from, okay, cost. Okay. Pressing difficulties, availability, cost, a lot on cost. So availability and cost, patient adherence, sensitivity, turnaround time, cost. So I think this sets the stage with our discussion, and I am very hopeful, and I know that the panelists can discuss all of this. Antibody and serotype usually not done. Okay, that's one of the things that I think we had in our discussions also last night. All right, so negative dengue test despite clinical picture of dengue, sensitivity with comorbidities and compliance of patient, early predictors for severe dengue, inaccurate results, NS1 positive, test PCR negative, so incongruence with tests, negative tests on day 3 to 4 of illness, accessibility and cost. So this is a recurring answer that we've been having, so we'll just keep it on like that. All right, so thank you for all sharing those valuable insights. Your experiences highlight the real-world challenges we aim to address today. So these perspectives will certainly enrich our discussion. Now, to set the stage for our detailed discussion, first on the line, Dr. Solante, with your extensive clinical experience, could you open our panel by sharing your perspective on when and how dengue diagnostics are warranted in a clinical setting? I'll do it sequentially, but this is the rest. So, what are the initial considerations for a clinician faced with a suspected dengue case? And how does the timing and type of diagnostic test influence your immediate patient management decisions? Please go ahead, doctor.
Yeah, thank you, Christine, for that. Now, first we'll have to look into the current landscape of the diagnosis of dengue. I know all of you have encountered a lot of these patients with dengue or suspected dengue. We usually start with the clinical manifestations, and it's usually the presence of fever. Okay? And when you look at further examination, the history, you have all the history of other systemic manifestations, and that's where the trigger that you need to test. Why? Because when you look at dengue is something that a lot of us has fear in terms of missing the diagnosis. Why? Because we see patients, even they're walking, but after 24, 48 hours, they go into severe dengue, or we miss the warning signs. Or within that context, within 2 or 3 days, there was a warning sign, but the patient was sent home. Now, currently, I'm talking of the landscape in the Philippines. We're now implementing the use of the NS1 RDT. Our data that for the past 5 years, since 2012 and 2016, I think Dr. Lulu can attest to this, that the Philippines has an average number of cases of 185,000 to like 200,000 a year. And we see trends of outbreaks during those periods. And our mortality rate or case fatality rate is 0.37 to 0.39%, one of the highest in Asia Pacific. So it's important when we educate the doctors, the frontliners, even at the level of the primary care, to the secondary, to the tertiary hospital, it's important that when you have a patient presenting with fever 2 to 7 days, compatible with dengue, first you have to rule out the presence of dengue over other infectious diseases. No? And that's with the use of the rapid diagnostic test. And precisely the point there is that its availability in most of these health stations, the barangay health station, the secondary level, has changed the ecosystem and on how we been reporting dengue. And that's the reason why probably you'll notice DOH will be reporting like there's an outbreak in this area, there's an outbreak in this area, driven by that part of that surveillance that we have in terms of increasing that particular awareness. So it starts with clinical symptoms and then using the rapid diagnostic test, the NS1, because it's cheaper, it's readily available, and not only doctors can do it, even the midwife, even the nurses or the barangay health unit, they're being taught by the National Reference Lab on how to do it and interpret and manage the cases.
Thank you so much, Dr. Solante. Very insightful. So I think that sets the stage for the rest of our panel discussion. All right, so without further ado, I will now go on to our discussion topic number 1. Again, I will direct you to the Slido. So anything that you would like to ask regarding our discussion topic 1, which is strengthening early warning through health system integrated testing and point of care testing. All right. So so building on what Dr. Solante said, our first discussion point revolves around this topic. We often focus on specific diagnostic tests, but there's a wealth of data within our health systems that can serve as early indicators. Now, my opening question to the panel is this: how can hospital laboratory markers, such as your high fluorescent lymphocyte count percentage, or HFLC percent, and immature platelet fraction percentage, or IPF percentage, along syndromic surveillance data, be effectively utilized as early indicators for potential dengue outbreaks even before confirmed cases surge. So furthermore, when point-of-care testing for dengue, when is point-of-care testing for dengue most appropriate? Although this has been discussed a little bit by Dr. Solante. So in what environments is it best adopted, and how does it fit within the broader testing landscape, from rapid point-of-care diagnostics to advanced genomic sequencing for surveillance? So, Professor De Alois, perhaps we can start with you, given your expertise in outbreak preparedness and broader diagnostic strategies. Please go ahead.
Thank you, Kristen. That's an excellent question. It's interesting. All of this morning, we heard about the whole suite of diagnostics we have accessible globally. But the reality is in Asia and in majority of the population in Asia, when they come to the hospital, majority of the time there's the first line testing is the CBC, so blood count. And, you know, monocyte numbers, lymphocyte numbers, platelet counts, they are good early indicators of an outbreak. But the issue becomes when there are other sort of infections. And I think we heard that from BioMaria's talk as well. So many of our countries in our region has chikungunya outbreaks, right, corresponding in parallel to their dengue. They have leptospirosis outbreaks. They have Zika as well. And what happens is clinically, as well as our CBC, it's very difficult to tell apart. That's right. So it's a really good early indicator, right? And that is frequently always done. But then we need to move into POCTs that are specific to your antigen, because essentially the patient care differs for these different pathogens, whether it's dengue, chikungunya, and leptospirosis. Interestingly enough, I think Dr. Sand already covered it. So POCTs, we want to get POCTs to a majority of patients in the community, but the reality is that majority of population in Asia don't have access to POCTs, right? A lot of treatment ends up being empirical based on CBC counts. So again, I think there's a lot of work to be done in that aspect, but definitely POCTs are number one most important for patient care. Another thing we're noticing is even though there are POCTs that are rapid tests, a lot of the times when they're implemented in hospital settings, they can be done with finger prick blood prints, but they end up actually being done in the laboratory. Again, that decreases the turnaround time and also the implementation. Essentially, you did ask about sequencing. So as we move from POCTs to molecular testing to genomic sequencing, now we start talking about outbreak control, preparedness, and response. A lot of the times what we end up seeing is we obviously need access to PCR, especially typing PCR. They do end up being mostly in reference laboratories in academic institutions. Very rarely do we find them in hospital settings. But again, we do need access to those molecular typing PCR as well, so that governments can come in and respond to outbreaks. Genomic sequencing, we heard a beautiful talk by Nathan. We do, through Asia PGI, we mostly actually use Nathan's primers and protocols. And again, this is something very, very important, and many, through Asia PGI, we work with many of the ministries and national public health laboratories to essentially make sure that they are able to sequence the dengue viruses that are circulating within their country. And that's important because, as we saw, there's a lot of diversity in dengue, right? Dengue is essentially 4 different viruses, but within the dengue serotypes, we get all these genotypes, and as Nathan showed, minor lineages, major lineages. And, historically, we did only sequence small sections, but now we have the technology to sequence all of the genome, and that might give us more indication of pathogenesis, kinetics, disease severity as well. We're not at that point yet, But I know many of those individuals in this audience are working on those very questions. So hopefully that gave a bit of a landscape.
Thank you so much, Dr. De Alvis. Just quickly following up with our two other panelists, if you have anything to add, or if you have a different perspective, or with regards to this question.
Well, it depends on what kind of tools you want to use for whatever reason. Because if you say early warning system under the lens of public health, the technology that you actually need is quite different in terms of managing patients in the hospital emergency room. For example, if you're interested in surge of cases and all of these things, the rapid diagnostic test comes into play, right? Because the non-structural bond protein, the IgM can actually be, the sensitivity is high if you are dealing with primary dengue infection. But at the emergency room level, you are more interested on secondary dengue infection, in which this test's sensitivity drops because the preformed antibody competes with the binding site, and that has been seen repeatedly in most of this meta-analysis on rapid diagnostic tests. So if you're interested in that's why you have questions that clinically dengue, but the test is negative. That exactly is, because the secondary dengue, the preformed antibody from the primary infection, competes with the binding site of the test. Sometimes you will get false negativity result. If you are interested in this clinical spectrum, that may not be the ideal test in some scenarios. You will go to a more serological testing where you can quantitate antibody response if you are really going to go gung-ho. Or you can do a test that is unaffected by the immunologic status of the patient, such as your molecular test, your NAAT, either PCR or isothermal. And that's for clinical diagnosis in terms of identity, because sometimes at the ER we cannot, 95 to 98% of dengue cases can actually be managed at home, right? It's the fear of the 5% that makes us decide to admit, otherwise I might miss it and I might lose my practice. No? So that fear is the one that increases the cost of care for dengue patients being admitted, lie in bed, an IV line, Netflix, and CBC every morning, as opposed to that particular bed being occupied by more complicated cases. So in terms of diagnostic requirement, that's actually the holy grail of dengue diagnostic. A test that would say, do I have the risk factor of shock at the early stage of the disease? So that one is still missing. But in terms of evaluating from a public health status, we have such technology that can identify the surge. And then at the public health level, we do not need to rely on a specific diagnostic test for specific individuals, because there are epidemiological tools that can actually be integrated into a surveillance system to actually predict potential outbreak scenarios before they go bad. So from syndromic level analysis in each of the hospitals to actually what's the behavior of that particular community, utilizing the power of artificial intelligence. So digital diagnostics in public health is something that is also a huge challenge to us working on dengue diagnostics and public health control. Another area wherein we can actually look into. So it depends on the question. Early warning system from a public health, our current technology will do that. Early warning system for shock, we don't have those. And this is where clinical acumen comes in, clinical experience, suspicion, to make those decisions per every patient each time at the ER.
Thank you, Dr. Destura. Since we are on the topic already, I'd like to ask more, and I think everyone set the stage that, point of care testing for acute clinical management of dengue has a very, very crucial role for management. I'd like to ask in our country, especially regarding their integration with more centralized lab data.
Well, like I share the comments of everyone. the major barrier is actually not sensi, specie, or it's actually cost. And in some cases, when we develop technology, we make the most advanced technology ever could be developed. Sometimes we forget about accessibility based on cost. So for me, that still remains a challenge. That's one. Second, we all know that we are dealing with a condition that is heavily affected by the antibody response. It also shares the same challenges in designing immunological-based diagnostics for dengue. So that is a challenge. So sometimes our role is to actually shoot for the virus rather than the immunological response. Unfortunately, if we go molecular-based, the cost again becomes an issue. So at the end of the day, newer technologies needs to be incorporated. Lower reaction volumes needs to be incorporated because it may be insignificant in others because insurance can pay for that. But for most countries with similar situations like here in the Philippines, if that is not addressed, we will be discussing about the same topic every year.
Thank you, Dr. Destura. Any additional thoughts from Dr. Solante or Prof. De Alvis? Or
Yeah,
yes, sir.
I can add to that. No? Like me as a clinician, when you have a patient in the emergency room presenting with acute febrile illness, what is my priority when that particular patient comes in? Okay. So first, I would like to clinical manifestation. Is there a warning sign? Now, the different stages of dengue will also have implications on the availability of your test. For example, that patient comes in because of a warning sign. I have to prioritize that I should know that this is dengue. Why? Because timely intervention, prompt management is the difference between mortality. Because we know that when you have a warning sign, that is already predictive of a patient that will go into severe dengue. So that's the current practice now. Now, why I'm telling this? Because there are limitations also of the point of care test. And we experience a lot of that. Patients with a negative dengue and the patients had warning signs. What's next? And I think Raul has mentioned that on the context of public health and a clinician, some of these tests will really complement one over the other. And timing is quite crucial when to order an RT-PCR, an isothermal, or even a serological test, IgG, IgM quantification. So for me, it's really more on anchoring those tests because of what I'm doing here will benefit the patient in terms of prompt clinical management.
That's right. So our diagnostics are only as good as our history and PE and good clinical eye. So very nice points there discussed. So let me just quickly go to our audience for any questions that you have for this topic. Yes, please, sir. Please approach the mic and introduce yourself and your institution. Thank you.
Thank you very much. This is such interesting. I just wanted to share, I'm from Nepal, and in our guidelines, we are making, during the outbreak situation, we just first do WBC count or platelets, because the government supply their RDT free of cost for everybody. During outbreak, everybody like to be tested. It's not possible. So we go for WBC count testing. Maybe it's not good practice. What do you suggest in this situation? Thank you very much.
Thank you, sir, for your question. Let me bring it to the panel. Anyone would like to answer?
For me, in terms of an outbreak response, I treat the situation like the entire community being a single patient, which means that in order for me to establish that particular goal in monitoring, I need to confirm at least 1, 2, or 3 cases within the community. And then if everyone presents similarly symptoms, all the surrogate tests can become supportive already of the suspicion. So in terms of cost effectiveness in an outbreak response, the ability to actually confirm 1, 2, 3, or 4 cases presenting similarly and in cluster, and whatever is the surrogate test around it, there is now a high index of suspicion that it's the same case because there were confirmed cases in specific areas within the community. And I think that's one way of responding to an outbreak when resources are really, really problematic, so you can do syndromic surveillance by clinical manifestation.
Thank you. Yes, Dr.
I think that was an excellent question. I think one of the things that might help is having some information on baseline epidemiology of the cause of febrile illnesses in your population. If that information was there and you know it's all dengue, then sure. But if there are, say, in parallel, another sort of lepto, your population is endemic for lepto or chikungunya, then that's when there's this confounding factors coming in. But I think maybe Dr. Salanta, from a medical point of view, maybe have another comment.
Yeah. I would like to comment on that based on our experience during outbreak when we have this dengue fast lane. How many of you here have experience or do you have a dengue fast lanes in your country? Si team. How about the others? Fast lane, dengue fast lane. How fast can you diagnose dengue fast lane? Like in our setting, that's part of the Department of Health response. When you have an outbreak, all tertiary hospitals should have a dengue fast lane to complement the deluge of patients that are in the primary and the secondary. Now, in that particular dengue fast lane, we have to select patients who have a warning sign and patients without a warning sign. Only those patients, priority, that for those with warning signs, you have to do an NS1 over that, aside from your CBC. Without warning sign, then you have to monitor the patient, get the CBC, and then daily they have to go back to the hospital for monitoring. There are some loopholes in that because in some patients without warning signs, there are also overlap that sometimes the sensitivity, specificity of some of these warning signs may not be high enough that the clinician can recognize it. And that's the area that we need to teach the clinician in terms of it's not only about the presence of a warning sign. Like example in our hospital, adult, we are now doing testing without warning signs for those with comorbidities. Because we see a lot of these adults with comorbidities also going into, without warning signs, but they go into severe dengue. So we look into the economy in terms of prioritizing patients, but you have to look into an alternative also that for those patients that will not be tested because of the limited number of kits, you have another alternative pathway that you can monitor these patients.
Thank you, Dr. Solantin. Any other thoughts from our panelists? This is a very nice question. I think we have all learned from that, and I think we can all benchmark from the answers of our panelists. So, just quickly looking on the room if we have any other questions for our first discussion topic. All right, so moving forward, our discussion topic number 2, let's discuss the crucial intersection of testing with prevention and vaccine strategies. As new dengue vaccines become available, the role of serology in informing vaccination planning becomes even more significant. So, I'm addressing the panel now, how can serological testing, specifically IgM and IgG assays, be strategically employed to identify high exposure areas or populations that might benefit most from targeted vaccination campaigns? Okay, so that's the first part of the question. Anyone care to answer?
Well, there are guidelines for serological testing in terms of evaluating the host of that particular community. Unfortunately, it needs to be validated if the immunological response to the flavivirus is really dengue because of the cross-reactivity issue for seroepidemiological studies related to vaccine readiness of that particular community. So aside from doing seroprevalence study for dengue, this needs to be confirmed by a much higher serological studies, such as plaque reduction, neutralization, to make sure that this particular immunological response is through dengue, not just the generic, unless that is really fully validated and uniquely specific to the virus, to the dengue virus, such technology. That's one. So in terms of doing vaccine strategy program, this needs to be in place in terms of making those decisions in terms of readiness. No? And of course, it depends also on the type of vaccine that's being developed, right? So the preparations for monitoring depends also on the type of the vaccine format they are actually working on. And I hope they are good enough to cover all four. Yeah.
Thank you, Dr. Destura. Very nice points. Let me just quickly bring this to our vaccine expert, Dr. Rookie. Any thoughts?
Thanks, Christine. I think in addition to what Dr. Destura added, I mean, doing seroprevalence studies, especially, and I know several of us in the audience are also running these, it gives us information on, you know, what are the age groups in different settings that are at highest exposure to dengue. So it allows for vaccine trials, which age groups to target, which regions to target. Addition to serology, and there's a lot of benefits to that. I'm an antibody person. But I do think it is worth looking also at T cells, cellular immunity. I think that has not been explored historically, and it's worth looking at it. And it's not something that, I mean, you can't run as many samples as you do for serology, but it's worth looking at the cellular immunity and the baseline immunity in the population prior to starting your vaccine trials. In addition to immunology, I'm going to put in a plug here for genomics as well. Potentially good to also sequence the strains before, during, and after your vaccine trials, so that if you do see certain, you know, reduction in efficacy in your vaccine trial for certain serotypes, you know, maybe we can then ask the question, is it because of what's circulating? I mean, the vaccines currently do have older strains integrated into them. They are still showing efficacy. It's, you know, they are still working. But again, if we want to glean extra information on your vaccine efficacy trials, it's probably good to sequence the strains.
Any further questions from the audience?
Question here. Question.
Oh, yeah, please go ahead, Doctor.
Dr. C.C. King from National Taiwan University. As far as I remember, Philippines has a lot of experience on vaccine trial, and after your after you use the Pasteur vaccine, you had a lot of cases, and the parents are so much afraid about vaccination, not only for dengue, but also for measles, mumps, and other pediatric infectious diseases. So I would like to learn from the Philippine public health people or physicians, and how do you solve this kind of parents' worry problem? And have you recovered so far? And so because in the United States and the European country for COVID-19 vaccine hesitancy is a major problem right now. So I would like to learn how Philippines overcome this.
Thank you very much for asking that question. I think this question is digging deeper into the hearts of our Filipino physicians. Okay, so let me just throw it to the panel. I'm looking at Dr. Solante and of course Dr. Destura. Who wants to go first?
Well, vaccine hesitancy is not unique to the Philippines. It's because of misinformation being generated and the fear that it's actually being sent out to families and parents, affecting our perception on how good vaccines are in preventing deaths. So, especially now with the age of social media, the fear for vaccines is multiplied and done more dramatically, for most people who have the least information to be swayed that it's actually bad for you. Even in the most developed countries, we're now having measles outbreaks, no, because of vaccine hesitancy. As an infectious disease practitioner, part of our responsibility is to really fight these misinformations and to educate people. Lessons we have learned, a lot of not to assume that people actually understand you about its benefit. To assume that the information you have generated will reach the entire target population. I think part of the one important aspect to combat vaccine hesitancy is to really invest on very good science communicators, no, that understand the general language. Because sometimes you think you are already laymanizing your statement, and then your patient, out of fear of being misunderstood, will just nod and pretend he understood, no? But at the end, he's confused. So not all of us have the skill in providing the proper educations on vaccine adaptations. But vaccine hesitancy is, I think, one of the biggest challenge we will be facing in the next couple of years. So for me, the most important lesson learned, education needs to be studied very well on how to effectively implement those programs.
Thank you, Dr. Destura. Dr. Solante?
Agree with Raul. Now, I would like to share our experience during COVID. Remember when we had COVID and we have to give the vaccine mandatory to the healthcare workers. We have what we call prioritization, the healthcare workers, those who are elderly and those with comorbidities, and then the rest for the general population. Remember, during those times, the only vaccine that was available was the Chinese vaccine. And when we were evaluating it, the efficacy of that vaccine was only 50%. So they criticized us, why are you giving that vaccine when in fact that's only 50%, while the other vaccines like the Western vaccines have higher efficacy. So what did the government implement then was talking points, inviting all the experts, that includes some of our experts here, to give the correct information. Why we need to give the vaccine? What's the benefit of that 50% versus the 0%? Okay? Yes, there are adverse events, but you also have to communicate properly what are these adverse events specifically. Because when you want to head-on collide with the anti-vaxxers, they also always have answers to what you are talking. So it's important that you have to base your answer on data, on scientific evidence, and stick to that and be consistent with your messaging. Otherwise, there will be really problem with misinterpretation of that particular program.
Thank you, Dr. Solante and Dr. Desura for sharing your thoughts. So it's basically public education, patient education, and engagement. I also would like to add on that as we are all practicing clinicians and pediatricians and adult specialists, that we draw on our practice to establish rapport with our patients, and most especially if you're involved in public health, to really take the time, aside from presenting data and knowledge, to really engage your patients and address specific fears and questions from your patients, to make sure that your personal and professional reassurance really is there. Yes, please do.
Now we are talking about hesitancy of the community, but how many % of the doctors are hesitant to give vaccine? I think that is also another good thing to survey, because we have problems sometimes. Doctor contradicts another doctor on vaccine. Okay, and that hesitancy make it even worse, because it's between the words of another doctor and against another doctor about the efficacy of the vaccine. And that is one important thing. I think we should actually learn about hesitancy of doctors or people in the medical field about immunization. Okay? And the other thing is, Sometimes I think the hesitancy has got to do with what you said just now, the rapport and the trust of the patient to the doctor. Okay, if they trust them over a period of 30 years of good service or maybe 40 years of good service, they will know that I will trust my life to you. But if you get a new doctor were to go around and then giving all these talks and giving lectures to patients that they don't know, you may not get them through. So what is important is in a committee, maybe you get people who are influential, that committee, doctors who are influential to actually go out and educate that particular committee. Okay, do it in a local level rather than do a newspaper, social media. You just go use the local doctors who can be trusted, go to the local committee, and then spread the news. And because we've been trusted over many years, most likely they will trust the doctors more than the politicians. Okay?
Thank you, Doctor, for your thoughts. Very thought-provoking discussions that we're having. Now, let me just quickly get to one question from the Q&A. So, how will dengue vaccines affect the accuracy of dengue testing? So, can anyone from our panelists answer this? How can dengue vaccines affect the accuracy of dengue testing?
Well, it depends on the type of dengue vaccine you're actually using, which targets they actually designed it for. If the targets is similar with the targets of the diagnostic test, then there may be some competitions, no, in terms of its sensitivity. No. But if you're really more interested whether is there an active disease or not in this case, then you use a diagnostic test that targets the virus, not the immunological response. In this case, NS1 or the nucleic acid material. Unless your diagnostic test doesn't target the same targets that your vaccine is using, no? Sometimes it's a chimera wherein, the antigens utilized is almost similar in terms of your design, then the sensitivity will go down or the specificity will go down. So if you're interested on identifying if it's really active dengue, you go for its antigen or its nucleic acid, but the downside is you need to capture them within the first 0 to 5 days of illness. Beyond that, you can do serological testing. And then, of course, plus clinical manifestations. Yeah.
So, very important to know what vaccine is given to our patient, whether it's the first generation or the second generation one, what type, and also the test employed is very important, whether it targets any of the things that are in the vaccine. So anything to add? Yes, Dr. Rookie?
I might just add a comment. So some of the vaccines are shifting sort of the viremia period, right? It's shrinking the viremia period and so on. And so if exactly it is getting shorter, it's obviously reducing symptomatic. So I think in the vaccine trials, we need to decide what is our endpoint. I think Enyong also brought this up. Is it infection? Is it disease? Because if we're trying to capture infection and we know some of the vaccines are actually restricting that viremia period, then we need to change our strategy, diagnostic strategy. But I think as a community, we'll have to decide what's important. Do we need vaccines that prevent symptomatic dengue, or do we need vaccines that also prevent infection?
Thank you, Dr. Testura, Dr. De Alvis, and Dr. Solante. Any other questions from the floor before we move on to our next topic? All right. Oh, yes, please go ahead and approach the microphone.
I have a question about the vaccine strategy that, as we all know that subsequent infection with different serotypes of dengue can cause hemorrhagic fever leading to shock due to already produced antibody against the previous serotype. Can vaccination also cause this type of adverse situation? Because if the vaccine contains all the serotypes against all the serotypes, then can it create hemorrhage or shock in our body?
So that's a very common question that we get from our clinical practice. Anyone care to take that on?
Yeah, I think it's pertaining to the antibody-dependent enhancement.
Yes, the ADE.
Especially for the experience that we have with first-generation vaccine, wherein those who have been exposed are unlikely, but those who have not been exposed and you will be given the vaccine and then you'll be exposed to the disease, then you have that risk, okay, theoretical risk that it can be a secondary dengue because you were exposed to the vaccine. Yes, that's still one of the, not fear, but possibility, okay? But when you look into the context of that ADE and giving vaccine in general, the benefit of that vaccine, it's still the benefit of that vaccine that supersedes that risk of ADE. Okay? And that's the value now here, that when we look at trials of vaccines, always look at what is the response for those with seropositive and seronegative. Then you followed up all these patients over the 5 years. That's part of WHO recommendation. And how many of those who develop severe dengue for the seronegative and those with the seropositive. Okay? So that's a possibility, but that should not be one of the important considerations when you'll be giving a vaccine.
Okay, but what if I was somehow infected with dengue, but I was asymptomatic that time, and now I have taken the vaccine and it created adverse situation?
Okay, so if you were asymptomatic and you have, how did you know that you have dengue? I think Raul mentioned, expounded that with the serologicals. Then I would say you are a good candidate for the vaccine. But again, we have to have a good communication with that, because majority of patients with dengue are also asymptomatic. Okay? And in the first generation vaccine, the recommendation then was you don't give the vaccine if you are negative, exposure negative, okay? Only for those who are positive. So that always brings some area of hesitancy and fear, okay? And that's why when we will be looking at vaccine as someone or an intervention that saves life, that's more important for me rather than discussing that. It's just a way of how do you interpret the result? How do you look at this particular data? And when you will be communicating and giving this recommendation, it should be part of a very good communication that vaccine will save you over that small element of an ADE.
Definitely, Dr. Solante. Yes, Dr. De Alvis, any thoughts?
In addition to Dr. Salant, what Dr. Salante mentioned, which is true, even the first generation saved lives. I think the second generation vaccines, we are a lot more stringent. We learned from what happened in the first generation, and now the safety, they are observing it for longer. We are dividing it by naive versus immune. So I think whatever comes next would have gone through a more rigorous safety profiling.
Definitely, Dr. De Alvis. So, very nice question. I think, of course, in the Philippines, we do not have the dengue vaccine, so we don't have protocols for the administration. But in some countries where dengue vaccines are administered, I think there are protocols that are observed with regards to specific vaccines. That when you administer the first generation ones, there is a prior testing that has to happen. But in the second generation ones, I think this is something to do with the chimeric nature, the yellow fever code, and the second generation one, I think, uses DEN2 as a viral code. So things like that. There are certain controls that are in place in the national immunization programs where dengue vaccines are implemented. Very important for clinicians to be in the know with these protocols. Did we answer your question?
Yeah, thank you.
Thank you very much. Yes, doctor.
Sorry, I'm actually a pediatrician, so I'm very naive when it comes to infectious disease, because I'm also a pediatric cardiologist. Just that I think I overheard just now that actually the second generation dengue vaccines are actually T lymphocyte mediated. And is it possible that to reduce the cost, because it's prevention strategy, can we give one dose only? And then for those, especially for those with already a secondary infection before. So it will be nice if your panel can say that, and then maybe we will start a proper study to do that, and then we reduce the cost by half. I will not be sponsored by everybody for sure.
Well, the answer can actually be yes and no. It depends on the amount of immune response generated by the first dose. That's one. Second is how long is the response sustained with the first dose? Because what we do not want is to have a sense of false sense of security that I'm actually safe. So sometimes the level of protection depends on the degree of antibody response that we have. So if that is not sustained, sometimes you will have infection again before you develop clearance. And we don't know if that infection is mild or severe. That's what. But if, for example, the design of the vaccine is even with just a single dose, you will have a sustained response, and then one dose may be enough. But it really cannot be same for all. It has to be vaccine type and design specific to make those type of guidelines. But I understand like a priming effect, but I have reservations with half dosing. Yeah.
I'm not sure about. I think the vaccine has been in for quite long on second generation. Do they have any retrospective study about these people who take vaccine and what happened to them over the period of maybe 5 or 6 years? And the numbers that they have, is it significant? That actually can alter the policy for us next. Because we actually give some vaccine. Sometimes we have defaulters. And they come back not wanting the vaccine, especially the adults, male, adults, gentlemen. Normally they don't like the needles. So they actually take one dose and say, I'm coming back again.
Yeah. Can I just add to that? Remember, when you have a previous infection, you don't know what serotype do you have. When you're giving the vaccine, you have the 4 serotypes. So which means you still need, if the vaccine recommended is a 2-dose, regardless of you have a previous exposure, you need the 2-dose because your previous infection, you don't know what serotype you were infected.
Yeah, but from I think earlier lecture, we actually saw even the serotype of the others actually elevated for those people who are already got the first infection. So especially for the present second generation vaccine.
I think that's a interest. It's actually a very interesting and probably important question to answer, because obviously dengue epidemiology shows that tertiary and quaternary infections are rare, right, symptomatic. So the only way we would actually have the answer, and I know Enyong said 1 dose, I think is potentially to do the clinical trial.
Yeah, the clinical trial.
Yeah, it's worth doing.
It should be either prospective or even retrospective. Retrospective will give us the earlier result. Prospective will give you a definite protocol. I think that should be done. Okay.
Thank you. So I think a lot of questions here, but let's move on to discussion topic number 3. Our next topic focuses on the practical application of testing in case management during outbreak response, and critically, how we can improve access to these vital tools through policy. So let's discuss the specific roles of NS1, NAATs, and complete blood count in hospitals and clinics for dengue diagnosis, patient monitoring, and even identifying serotypes during an outbreak. So what are again, the Slido is in the screen for you to scan for your questions. So moving on, what are the current barriers to access, affordability, and timely turnaround for these critical tests in various healthcare settings? And building on this, from a policy standpoint, how can we achieve improved access to these diagnostic devices, from rapid tests to more sophisticated genomic sequencing in different healthcare settings, particularly in resource-limited areas. Okay, so again, just what policy interventions, incentives, or perhaps public and private partnerships are most effective in bridging these gaps? Very loaded questions. So I'll go through all of the panelists. Perhaps anyone wants to go first?
Okay. So on the perspective of testing in terms of case management and outbreak, it will depend on what is the current healthcare system infrastructure. But if you're going to look at it that way, you have to prioritize the primary care. Why? Because this is where people go, and accessibility to examination, to this test, will be very crucial. For one, it should be highly accessible for a primary care to diagnose dengue. Very important implications there. If you have a patient with dengue in the primary care and you need to refer that, then you have to have a referral system that this patient will have to go to in terms of when you diagnose dengue, and who are those patients that can be managed in the primary care. Now, in our setting, like the Philippines, there are really gaps in that, no? Because our system here of health delivery is decentralized, meaning it's the local government that will really fund the testing of this availability of NS1. And depending on the priority of the local government, that will now give you a determinant of how much they will spend for that particular test in order to test all those who have dengue in that particular local government. And that is where funding really has to be prioritized, because not all local government units have the same income and have the same budget. So I think that's on the perspective of the primary care. In hospital setting, like a provincial hospital or tertiary hospitals, not much, because that is part of the allocation when you look at testing, and we have to prioritize dengue testing, leptospirosis testing, chikungunya, and what other tests that are related to diagnose patients with fever.
Thank you so much, Dr. Solante, for your very important clinical pearls. Moving forward, Prof. De Alvis, given your work with Asia PGI, how crucial is genetic sequencing for tracking virus mutations during outbreaks, and what policies are needed to integrate such advanced diagnostics effectively?
Thank you, Christine. So I do want to first mention the barrier, especially for sequencing. In addition to what Dr. Solante said, for diagnostics in general for dengue, sequencing is additionally complex, and very few, again, every country in our region is sequencing, but at very low capacity. Especially the technical capabilities, the financial barriers, the supply chain, laboratory implement and upscale. However, genomics, there are use cases like pathogens such as TB, where, the TB field is taking NGS, next generation sequencing, to the clinics. They really want to do patient management and really predict AMR profiling and so on. Dengue won't be that, right? Dengue sequencing will essentially inform outbreak preparedness. It'll inform national public health laboratories and ministries whether there has been a serotype change, whether there has been a genotype change or genotype replacement. It could also, as we do more and more sequencing and study more and more, we could learn more about mutations that lead to more severe disease. So that can inform our governments whether we need to be prepared if a certain strain enters our population. So sequencing really does have a lot of value, especially for dengue and arboviruses, but it'll probably be not in patient management. It's most probably in outbreak preparedness and response.
Correct. Thank you, Prof. De Alvis. Follow up, Dr. Destura, from a research and development perspective, what policy support is needed to foster the development and local production of affordable and accessible dengue diagnostics?
Well, one is the use of locally developed platforms actually provide us that sustainability mechanism. So at the national level or a policy level, to adopt technologies that actually enhance technology development within the country can actually be a good model to scale things up to a level of affordability. Second is it depends on also on what type of technology you want to develop for what purpose in the multifaceted management of dengue. If it's for a surveillance purpose, our current technology can already do that. But to add, the genomics platform can actually be utilized in outbreak preparedness, whether either you do haplotype studies for immunological escapes that makes it more virulent or not, or in the presence of a vaccine implementation program, and then an outbreak happens, and you will be very interested what led to the breakthrough outbreak. So another technology may be utilized, and these were the genomics aspect. No? But in terms of diagnosing, in terms of diagnostic gap, one is a technology that actually unaffected by the patient's immune status for clinical management that is affordable is what actually needed. Second, a diagnostic technology that can provide predictions whether you will go into shock or not can save a humongous amount of healthcare costs in decision making. So in terms of research and development, these are the research, the diagnostic questions that hopefully most of us who are in the area of diagnostic research can actually look into. We have looked at transcriptomic signals, we have looked at proteomic signals as predictive markers for dengue shock in some of our partners, and there is really a huge window that can actually be explored, especially now that we have the access to high computing system is way better than 5 or 10 years ago, when you can actually do a collective analytics of 10 years of work in the areas of transcriptomes and proteomes, and even microRNA technologies platforms that can help us identify really strong predictive markers for dengue shock in this case. So those are my R&D wish lists in diagnostics.
Anything to add from our panelists on this topic? All right. So we've covered a lot of ground on case management, outbreak response, and policy. Let's take a final round of questions from our audience, specifically on these important aspects. Please step up to the microphones if you have some questions. Any questions? Or in the Slido? I think we learned a lot from our panelists today. So before we conclude, sorry, there is? Okay. So, there's a question here. Let's say we improve the availability of dengue diagnostics in the rural areas. Isn't this also an ethical dilemma if we diagnose but cannot treat due to lack of resources? Thank you for this question. Anyone who would like to take this on? Yes, Dr. Solante.
That's a reality, okay? Especially now that talking about the Philippines, in rural areas, we lack doctors. And that's the reason why the Department of Health is enhancing the specialista ng bayan, meaning they want to increase the doctors in the community, okay? Because when you will be doing that, you have a test, but you don't have someone to manage the case, then that's a big problem.
That's right.
But probably on that note, it's important that when you will be communicating with this level of care, the primary care, it's important that they should know when to refer and how to refer. I'll give you just a short example. Why is San Lazaro catering for a lot of patients with dengue during outbreak? These are patients from nearby municipalities that the thought that their doctor, they have doctors, but even their doctors would like to refer these patients, even without warning signs, all of them would like to refer to the tertiary hospitals. That's the problem, and that's, I think, the essence why we need universal health care in order to build up the capacity of the primary care. And part of that is also diagnosing and management of these cases.
Thank you, Dr. Solante. Facing that reality, it varies. Diagnostics is only one prong in our response, but basically we have to know and coordinate with the rest of our community into what's available, and of course get that support from everywhere that we can so that we can make our response more holistic and effective. All right, so before we conclude, I'd like to ask each of our distinguished panelists to share one concise key takeaway message that they hope our audience will remember from today's discussion on dengue testing, perhaps focusing on what they see as the most impactful next step for our collective efforts. So, anyone would like to go first?
Well, the most powerful diagnostic tools that you have is your training. Because at the end of the day, if you're thrown into an island and you don't have any diagnostic test, you cannot just cry out of frustration and say, I can't treat this patient because I don't have a diagnostic test. So the most powerful diagnostic tool is the clinician. So we really have to harp on training and enhancing our experience in clinical management.
Thank you, Dr. Destura. Prof. De Alvis?
So we discussed a wide variety of diagnostics, and we realized there's strengths and limitations in each one of them. So when we go to implementation at a national level or regional level, it's probably good to take into account the local sort of what is happening locally, the enabling environment, like we discussed, the barriers. But the game changer, I think, and we've sort of brought it up, each one of us, I think, the game changer for those of you who are doing R&D for patient management is potentially a predictive diagnostic of severe dengue.
Thank you. Dr. Solante?
Yeah, I think all the speakers here have really made an important take-home message in terms of diagnostic testing for dengue. And yes, dengue is still a very important infection that we have to deal with. Whether you have that diagnostic test or not, it's important also that as a clinician, you have to harp on the value of the clinical eye, because this test will not be possible without you suspecting that this patient has dengue. Thank you.
Thank you, Dr. Solante. So again, thank you, Professor De Alvis, Dr. Solante, Dr. Destura, for those valuable insights and this truly enlightening discussion. Your expertise has proven us with a comprehensive understanding of how testing strategies are integral across the entire continuum of dengue control and care, from early warning and patient management to vaccine strategies and outbreak response, all while considering the vital role of policy and accessibility. I also want to extend my sincere gratitude to our engaged audience for your presence and your thoughtful questions throughout the session. We hope that this session has provided you with our valuable information and sparked further thought on how we can collectively strengthen our fight against dengue. Thank you again and enjoy the rest of the conference.